I'll be spending the next half hour on an important topic, the topic of ectopic pregnancy. As you can see here on my title slide, I'll be talking about a variety of different kinds of ectopic pregnancies. The slide on the left shows a live ectopic in the left fallopian tube. The slide on the right shows what we call a heterotopic pregnancy, one inside the uterus, one pregnancy inside the uterus, here we are with a heartbeat, and one in the left cornu of the uterus. The overview of the talk that I'll be giving, I'll be covering both diagnosis and treatment. I'll start out my talk with some basic rules of diagnosis of ectopic pregnancy. I'll move on from there to some pitfalls in diagnosis as well as diagnosis of unusual ectopic pregnancies. And then I'll move on briefly at the end of my talk to discuss ultrasound-guided treatment of ectopic pregnancy. Ectopic pregnancies occur in a variety of locations. The most common location is in the fallopian tube outside of the cornu of the uterus. And that can be in any one of the isthmic, ampullary, or fimbrial portion of the tube. About 95% of ectopic pregnancies in women who conceive naturally occur in the extracornual portion of the fallopian tube. The other 5% of ectopics, although a higher percentage of ectopics in pregnancies achieved via assisted reproductive technologies such as in vitro fertilization, about 5% occur in uncommon locations, including heterotopic pregnancies, which is a combination of a intrauterine pregnancy and a simultaneous ectopic pregnancy. Pregnancies in the interstitial portion of the tube, the portion of the tube that traverses the cornu of the uterus, is another kind of unusual ectopic pregnancies. Cervical implantations are another form. Intra-abdominal pregnancies are rare, and a variant of ectopic pregnancy is a pregnancy that is implanted in the uterus but in a cesarean scar instead of in the central portion of the body of the uterus. And I'll be talking about all of these, both common and uncommon forms. So let's now get into the sonographic diagnosis. We'll first start talking about some of the basics before we get into some of the more advanced aspects of diagnosing ectopic pregnancy. The clinical setting in which ectopic pregnancy, in which we do ultrasounds to look for ectopic pregnancy, are women who have a positive pregnancy test. In other words, a positive beta HCG test. That's the serum pregnancy test. A woman who has a positive pregnancy test combined with symptoms of pain or bleeding is one in whom we, when we're doing an ultrasound, are doing it to rule out ectopic pregnancy. So we suspect ectopic pregnancy clinically in women with a positive pregnancy test and symptoms of pain or bleeding, and we often call such a patient a rule-out ectopic patient. And the key questions, for the reasons that we'll see in a minute, in a rule-out ectopic, when we're doing ultrasound in a rule-out ectopic pregnancy, are, number one, does the ultrasound demonstrate an intrauterine pregnancy, an intrauterine gestational sac? And the second key question is, are the adnexa normal? The ovary and regions around the ovaries outside the uterus, are they normal? The reason these are the key questions can be seen from this table. This table is based on an article that was published some years ago by myself and Dr. Douglas Brown, who's now at the Mayo Clinic. And what we did was we summarized the data in the literature to come up with the likelihood of ectopic pregnancy in a patient with a positive pregnancy test, symptoms, and no intrauterine gestational sac. In such a patient, what's the likelihood of ectopic based on what we see in the adnexa? And importantly, as you can see from the left-hand heading of this chart, the likelihood of ectopic depends on the extra-ovarian adnexal findings, the findings in the adnexa outside the ovary. And why is it important that it's outside the ovary? Well, in a patient with a positive pregnancy test, anything inside the ovary is likely to be a corpus luteum, so it is largely irrelevant. But what's very relevant is what we see in the adnexa outside the ovary. Again, this is all, as you can see in the heading, in a patient with a positive pregnancy test, symptoms, and nothing in the uterus. So if the extra-ovarian adnexal findings are abnormal, then the likelihood of ectopic pregnancy is very high. For example, if the adnexal findings outside the ovary, if in that area we see a mass with an embryo or a yolk sac, then of course the likelihood of ectopic pregnancy is 100%. We've seen the ectopic. What about a rule-out ectopic patient in whom we don't see an embryo or yolk sac in the adnexa, but we see a lesion outside the ovary that is surrounded by a bright ring called a tubal ring? And we'll see examples of all of these in a minute. Then the likelihood of ectopic pregnancy is 95%. If we see in a rule-out ectopic patient any complex or solid mass in the adnexa outside the ovary and outside the uterus, the likelihood of ectopic is slightly lower, but it's still over 90%. If we see free fluid with nothing else, as long as it's at least a moderate amount of free fluid in a rule-out ectopic patient, in our analysis we couldn't give a number, but we know that the likelihood of ectopic is quite high in a patient with a moderate to large amount of free fluid, positive pregnancy test, symptoms, and nothing in the uterus. Now at the bottom you see the situation in which our patient who has a positive pregnancy test, symptoms, nothing in the uterus, also has nothing in the adnexa, at least nothing outside the ovary. So there may or may not be an ovarian lesion, but we ignore those as corpus luteums. So if the adnexa outside the ovary is normal in such a patient, the likelihood of ectopic is far lower than when the adnexa are abnormal, but it's not zero. In other words, if we see a rule-out ectopic patient, we see nothing in the uterus, nothing in the adnexa, the likelihood of ectopic is down at about 5%. So it's fairly low, but not anywhere near zero. So based on these numbers, we can put together the following diagnostic algorithm or diagnostic chart. If we start with a patient, a rule-out ectopic patient, one with a positive pregnancy test and symptoms of pain or bleeding, the first test would be an ultrasound. And the first question to ask when we do the ultrasound is, do we see an intrauterine gestational sac? If the answer to that is yes, an ectopic pregnancy is virtually excluded. The chance of ectopic, if there is an intrauterine pregnancy, is well under 1%, probably under 0.1%. Doesn't mean that we shouldn't look for it, but to all intents and purposes, the identification of a pregnancy inside the uterus rules out a pregnancy outside the uterus, an ectopic pregnancy. If we do the ultrasound in this rule-out ectopic patient and the answer to is there an intrauterine gestational sac identified as no, we don't see one inside the uterus, then the key question is there an extra-ovarian mass, an extra-ovarian complex or solid mass? And then the possible answers to that question are yes, there is one with a yolk sac or an embryo or yolk sac. So if we see a complex mass outside the ovary in the adnexa with an embryo or yolk sac, we've diagnosed a definite ectopic pregnancy. Likelihood is 100% of ectopic because we've seen the embryo or yolk sac. If the answer is yes, there is a mass in the adnexa, but there's no embryo or yolk sac, then the likelihood of ectopic is not quite 100%, but it's very high, over 90%. And finally, if we see nothing in the uterus and nothing in the adnexa, then we don't know where we stand. The differential is ectopic pregnancy, as we saw from the prior table. There's about a 5% chance of ectopic. Or it can be an intrauterine pregnancy that's either a failed pregnancy, and that's why we're not seeing it, or a normal intrauterine pregnancy that's just too early to see.